Hello and welcome to the 1800 RESPECT webinar, Family Violence and the Perinatal Period, a guide to identifying and supporting those at risk of abuse. Thank you for joining us. Our webinar today is being presented on the lands of the Wurundjeri people of the Kulin Nation, who are the traditional owners of this land. We would like to pay our respects to their elders past, present and emerging, and elders from other communities who may be joining with us today. I'm Inez Carey, the Clinical Projects Manager for 1800 RESPECT, and I'm here to introduce today's presenter, Nicole Hyatt. Nicole is the founder and Executive Director of COPE, the Centre of Perinatal Excellence. Prior to this, Nicole was the former Deputy CEO and National Perinatal Advisor of Beyond Blue. Her role in the perinatal area included oversight of the National Research Program, advocacy, and the implementation of Australia's $85 million National Perinatal Depression Initiative. Other areas of specialisation within the perinatal field include consumer research, national community awareness campaigns, clinical guidelines and resource development, digital screening, and research and advocacy to inform and guide policy and best practice. Her leadership and strong commitment to perinatal mental health resulted in the formal establishment of COPE in 2013. For many people, pregnancy is a time of joy and celebration. However, we also know that violence against women often increases when they are pregnant, and some women will experience family violence for the very first time during pregnancy. If a woman is already experiencing abuse from her partner, this is likely to increase in severity when she becomes pregnant. Women aged 18 to 24 are most at risk of experiencing intimate partner violence during pregnancy, more so than any other age group. For many women who experience abuse and sexual violence, being denied access to birth control methods and options can mean that pregnancy is an unintended outcome of violence, or they may be forced to terminate their pregnancy. What we also know, though, is that pregnancy and early motherhood is a time when women increase contact with health services and other professionals. This may provide greater opportunities for early intervention and support for women. This webinar will outline the types of intimate partner violence that can present during the perinatal period, the impacts of abuse on the physical, emotional and mental health of women at this time, and how frontline workers can offer support. If you require support for yourself or someone you are working with, you can contact 1800 RESPECT for confidential information, counselling and support. We are available 24 hours every day of the year to support people impacted by sexual assault, domestic or family violence or abuse. People can access the service by phoning 1800 737 732 or by visiting 1800respect.org.au. This webinar is live and interactive, so please submit your questions as it progresses. At the conclusion of Nicole's presentation, we will try to answer as many of your questions as possible. I'll now hand over to Nicole, who will provide an outline of COPE and how they approach family violence in the perinatal period.
Thank you so much, Inez, and thank you for the opportunity to be here today and to talk to you about this very, very important issue. In today's presentation, as mentioned, I'm going to go through the research and in particular looking at best practice around how we identify and manage family violence in the perinatal period. I think I just go into next step. Okay, so also in today's presentation, I'm going to be drawing on the latest National Clinical Practice Guideline, which COPE developed for the Commonwealth Government, and this was released in October 2017. So the national guideline is based on obviously extensive research and review of the evidence-based research to inform best practice, and we'll focus on these in relation to family violence today. The guidelines are very extensive in that they cover a lot of evidence-based recommendations. Some of the recommendations there was not enough evidence for, so we had consensus-based recommendations and also practice points based on the views of experts around the table. The guidelines are also very extensive as in their coverage of emotional and mental health problems in the perinatal period. So the perinatal period is classified as the period from pregnancy and conception through to the end of the first year of the baby's life. So technically, when we're talking about perinatal mental health, we're talking about that 9 months of pregnancy, birth, and the first 12 months postnatally. So this is a time in a woman's life when we know she is most at risk of developing mental health problems. And the guidelines cover the identification, management, and treatment of these conditions. So depression, anxiety, bipolar disorder, postpartum psychosis, and also these new guidelines cover schizophrenia and borderline personality disorder in the perinatal period as well. The guidelines really talk about the importance of a number of areas, and one of those is around psychosocial education. So we know at the moment that a lot of people don't have good understanding about emotional and mental health at this time of life. So it's very important that we educate women and men around the heightened risk and how to identify these symptoms in themselves or their partners. The guidelines also go into extensive detail about screening and psychosocial assessment, which we're going to look in today's seminar as well. So this is how do we identify those women at risk through psychosocial assessment, and also identify those who might be experiencing the more common symptoms of anxiety and depression during their pregnancy and in the postnatal period. The guidelines also cover the important areas of referral and treatment. And that's very extensive when you think about treatment for mental health problems, and that can include, for example, what is the safe use of medication, for example, for the treatment of mental health problems when carrying an infant in pregnancy, and also the safe use of medication when breastfeeding, for example, in the postnatal period. So they are very extensive and quite complex guidelines in their coverage. Importantly, the guidelines also provide us with a lot of opportunity and insights into how we can do things more through innovation and sustainability. And so as part of today's presentation, I'm also going to draw your attention to new resources and ways that we can really address some of these issues, particularly for this at-risk audience. If you'd like to ever access your own copy of the guidelines, I'd encourage you to sign up to at this URL, so cope.org.au/HP sign up. And this will enable you to access the latest copy of the guidelines electronically, but also will keep you up to date with new resources for health professionals and for consumers in the perinatal period when it comes to emotional and mental health. And this might affect a number of the clients that you see in your work. So easy to just go on and register, and then you'll have access to the resources. We also, I just wanted to mention, have a free accredited online training program which is for health professionals and really frontline workers who might be coming into contact with women around emotional and mental health in the perinatal period. So this free online accredited training program is really giving you the skills to put the guidelines into practice in your role as a first-line health provider. So that's just a resource funded again by the Commonwealth Government, which might be of interest to you. But I'd like to now talk really about mental health in the perinatal period and go into a little bit more detail about that. We know that mental health conditions have a significant impact on not only the outcomes of the mother and her maternal outcomes, but also those of the infant, other children, and the broader family. So this is why it's very important when we're talking about mental health in the perinatal period, we're not just focusing on the mother, but also the family and the unborn and new infant and other children, as well as the partner. We know that women are more likely to develop a mental health problem when there's a range of different psychosocial circumstances, or what we call in the area risk factors for perinatal mental health problems. So let's just have a look at what some of these risk factors actually are and what places people at risk. So from developing the guidelines, we did a very extensive review of the latest literature, and these are the factors which are identified to place a woman at significantly increased risk of developing a mental health problem during her pregnancy or in the postnatal period. So if a woman has a personal history of mental health problems, so she's had mental health conditions in the past, or even if she has a family history, she is at much greater risk of developing or relapsing into a mental health problem in the perinatal period. Not having good access to supports from her partner is another risk factor, as is having major life stresses, particularly in the last 12 months. So this is a time of life where there's often a lot of change. People might be selling their houses, and there's a range of other stresses going on as they're adjusting to this new role of becoming a parent, or increasing their family size. And significant life factors like this or stresses can significantly also increase the risk, particularly for those with a history of mental health problems who are already more vulnerable. We know that certain personality traits as well, particularly having an anxious personality, is also a major risk factor. So here's someone who might tend to be a perfectionist, who feels highly anxious or worried if things are out of routine or out of order. We call that trait anxiety as opposed to state anxiety, which is something that comes and goes. So this trait or perfectionistic personality trait is also associated with having a greater likelihood of developing depression or anxiety, particularly in the perinatal period. Not having access to practical support, so that might be from family or friends or as well as partner. Having a history of abuse, and this includes a history of emotional abuse, physical abuse or sexual abuse. Because this is a vulnerable time and a time when people are often reflecting on their own childhood and their past experiences, they are more vulnerable and susceptible to mental health problems. And these factors really bring this to the forefront in this perinatal period. And that also extends to your relationship with your own mother. So if you have a poor relationship with your mother, as you are entering and becoming a mother yourself, you often reflect on your own maternal experiences with your own mother, and that can increase your level of vulnerability to mental health problems at this time. Having a history or current use of drug and alcohol, and also being in a family violence situation, these are all major risk factors which increase the likelihood that a woman will experience mental health problems in the perinatal period. Because we know these factors are risk factors, we do ask questions about these during pregnancy. Also, in the postnatal period, these factors are also known to increase the rates of postnatal mental health problems. So someone who's had a traumatic birth or a very negative birth experience, we know, for example, that could lead to a greater onset of anxiety and depression, and in some cases even post-traumatic stress disorder if their birth experience has been traumatic. Having a negative experience of parenting, so things like having a very unsettled baby, sleep deprivation, not being able to console or settle baby. When you have this cumulative effect of these factors over a period of time, they can also certainly take their toll on the emotional and mental health problems. And this also extends to feeding issues. So breastfeeding, for example, is something a lot of women aspire to, and it's not as easy as they think it would be. This then impacts on how settled the baby is, and impacts on self-esteem as a new mother and emotional and mental health. So these are all things that we know impact on the likelihood at this time. Let's just focus now briefly on the issue of family violence specifically, which is one of those risk factors that we've identified as placing a woman at greater risk. We know from the literature that women are 3 times more likely to experience family violence in pregnancy or the postnatal period. This is not unified only in Australia, but across the world, the estimates are around 4.9%. And in Australia, around 400,000 women are likely to experience interpersonal violence during pregnancy. In the postnatal period, this is also high, and research by Hannah Woolhouse and her colleagues at the Murdoch Research Institute estimate that around 16.6% of reported violence in the months following the birth of a baby. So it's a time of increased stress, not only for the woman, but also for the partner, and this can also, of course, impact on these rates of family violence. This, of course, has flow-on health consequences for the woman and for the family. We know that it results in increased rates of physical injury and health problems. That another type of family violence would be reproductive coercion, so the woman being forced to have children against her own will. Having adverse pregnancy and birth outcomes. Perinatal anxiety and depression, we know these are other major health consequences of family violence. Having an impaired experience of motherhood and parenting, obviously this flow-on effect of interpersonal partner violence impacts on her ability to mother and parent her infant. And also we know that having this family violence impacts on mental health problems, not only in the mother, but also the children and what the other children might be subjected to. That includes the health and safety of the infant, but also other children in the immediate and longer term. So of course we know that this, it stands to reason that this increases the likelihood of women alone developing mental health problems in themselves, and this increases the impacts and severity and flow-on effects both for her and the broader family network. So it's a very, very significant issue. And it's for this reason that we recommend, the national guidelines recommends that every single pregnant woman is screened to identify her likelihood of developing a mental health problem during pregnancy and in the postnatal period through universal routine screening. So really this is what the guideline focuses on, as I mentioned at the beginning of the presentation. And now I'm just going to move into looking at some of the solutions and the ways that we do this in practice in antenatal and postnatal and healthcare settings. So starting firstly with psychoeducation. The psychoeducation, traditionally we've done this by giving women booklets, emotional health booklets or booklets about depression or anxiety in pregnancy or the postnatal period. And this has been, certainly when I was at Beyond Blue before, this is how we did it under the National Perinatal Depression Initiative. But when you think about it, it's not a very sustainable approach. It's often quite restricted to people of English-speaking background. And also people often think, I remember when being at Beyond Blue, people would think, well, I'm not going to need that because I'm not going to develop mental health problems. So obviously they thought that the information was not relevant. So one of the things we really focused on at COPE when starting COPE was looking at how we could make information around emotional and mental health more accessible, more inclusive and more sustainable for women in pregnancy and the postnatal period. And the way that we did that is developing the Ready to Cope guide. So this is an e-guide to pregnancy and motherhood, and it's really a fortnightly email guide that women can sign up to at any stage of their pregnancy or the first year after having a baby. And on signing up, they will receive a welcome email, and then every fortnight they'll receive information that is relevant to the period of time that they're at. And this provided us with a great opportunity to drip feed the information that's relevant to them at the time. And certainly in this, we covered the different types of risk factors, getting women to reflect on whether they might be at greater risk of developing a mental health problem, getting them to think about protective factors. How can I protect myself against developing a mental health problem? Things like building your village, building your support networks, but also being aware of early signs of anxiety and depression and how they relate to stress and how you can manage stress. So these are all tips and strategies to help empower women with insights and information right throughout their pregnancy and the first year. So the Ready to Cope guide is free, obviously, and we promote it widely through healthcare settings, through posters, information, and women can sign up. And we've been currently funded by the Commonwealth Government to adapt this into 10 languages. So women will be able to sign up and receive this in their own language. And also we're adapting it for Aboriginal and Torres Strait Islander women as well. But certainly right now it's available in English and a great resource to make sure women are accessing information throughout their pregnancy and the postnatal period from Way to Go. So these are just some examples of the topics that are included in the Ready to Cope guide. Things like managing expectations. When you think about it, we have, when you're having your first baby, you really have no reference point. So often you're looking at beautiful advertising on TV and all those brochures which are telling you that what becoming a parent is supposed to be like. And often, of course, that far exceeds our expectations. The reality is quite different. So we really plant the seed about the reality of motherhood in a very gentle way and getting people to reflect on their current expectations and really challenge whether those perceptions are realistic. We talk about lifestyle issues, how to look after themselves, how to prepare for birth and recovering from birth, and also addressing topics that often people are not talking about, like what if your birth didn't go to plan? When is it time to seek help? We also talk about the impacts of becoming a parent on relationships and friendships. We talk about mother guilt and coping with the different challenges that commonly come with having a baby. We also focus on stigma, given the high expectations and the fear of being judged as not only not coping as a woman, but being a bad mother. When it comes to mental health, stigma in this area is quite unique and almost double-barreled, because there is not only that stigma of being identified as not being able to cope, but also not being seen as being a good or competent mother or parent. We cover the range of common and uncommon mental health problems, the risk factors, and also how to identify signs of relapse of the high prevalence disorders like depression and anxiety, but also the severe mental illnesses. So these are just some of the topics that we cover gently in the Ready to Cope guide. Coming now to screening and psychosocial assessment, which is another key recommendation of the guidelines. The guidelines recommend that we, as I mentioned, we routinely assess everyone for their risk of developing mental health problems, and this includes their risk factors, which we mentioned in the earlier slide. So the psychosocial screening tool is a series of yes, no, and rating scales where women are required to or asked to answer questions to identify whether these risk factors might be present. Typically in the antenatal period, this might be done by a midwife, an obstetrician, although to be honest, currently the rates of screening in the private sector are very, very low. This is for a number of reasons. Often in the private sector, I've done a lot of work with obstetricians. Often obstetricians think that's not their patients. My women don't have these risk factors or are unlikely to develop mental health problems. But certainly there's new Medicare item numbers and rebates for GPs and obstetricians to try and lift the screening rates in the private sector, because we know those women are just as at risk as the public sector, but often they were missing out. Despite paying more for their care, they were missing out on this so important as psychosocial assessment. In addition to looking at the risk factors, we're also looking at the importance of the impact of identifying these risk factors on referrals. Screening alone doesn't include the rates of referrals, but it certainly increases the likelihood of having that conversation. And there certainly is evidence around targeted screening for women who are pregnant or in the postnatal period, as opposed to universal routine screening right across the population. But certainly the guidelines recommend, both the perinatal mental health guidelines, which I've referred to today, recommend that we do routinely ask pregnant and postnatal women around family violence, and also the new National Antenatal Care Guideline, which came out earlier this year, also recommends universal routine screening for family violence. So to ask these questions, there's a new clinical tool called the Antenatal Risk Questionnaire, or the ANRQ. And on our website, we have the details of the instructions, the scale itself, and the scoring guide about how to use this tool to identify the level of psychosocial risk for a woman in the perinatal period specifically. So just focusing specifically on the family violence question, when the guidelines were developed, or the ANRQ was initially developed by Professor Murray-Paul Austin and her colleagues, they didn't include a question around family violence, because this was developed in an antenatal care setting, and family violence was being asked at a different point by midwives. So it wasn't actually included in the screening tool. So the committee of the guidelines came up with this way of asking the question, and we actually include it in the ANRQ. So we ask the women, do you feel safe with your current partner? And rather than yes, no, we give sort of more room or leverage for people to answer a range of responses, from not at all through to very much, and of course identifying those who might not have a partner. But in this case, anyone who answers a little or anything greater than that, we would certainly be inquiring more about family and intimate family violence. So as mentioned, this is all included in the antenatal risk questionnaire. And also, as I mentioned earlier, not only are we looking at psychosocial risk, but we're also looking at the likelihood that this woman in front of us might actually be experiencing anxiety and depression during her pregnancy or in her first year of motherhood. So to do this, the guideline recommends a scale called the Edinburgh Postnatal Depression Scale, which has been validated, or the EPDS, which has been validated to be used both antenatally and postnatally. And again, on our website at cope.org.au, we have the Edinburgh Postnatal Depression Scale and the scoring guide, and how to interpret and identify if a woman is likely to be experiencing anxiety and depression, and as a result require a referral. There's a lot of barriers to screening when you think about it, and this particularly, I suppose, is of interest in the family violence area when we're trying to look at these risk factors and have the opportunity to ask women around these factors in the perinatal period. So some of the more general barriers to screening include, for health professionals, a lack of time within the consultation. You know, midwives working in busy public hospitals talk about they're so time poor and there's so many different assessments and tests and things to ask about. So time is a great impediment to screening, and often why screening for mental health doesn't get done, and it's the first thing to often drop off. Physical health problems, urine testing, blood pressure, all those things always get put first, and mental health often slips through the cracks. The opportunity to do screening is also impeded, particularly in the family violence area, where a controlling male, for example, might certainly attend all the appointments for fear of the woman disclosing family violence. So often this makes it difficult for health professionals at the front line to try and have that opportunity with women. So I hear of cases where the woman might be going into the bathroom to do her pee on the stick to measure her protein levels in her urine, and the health professional is running after trying to ask the questions around family violence while the man's not there. So, you know, these are not ideal opportunities, and we need to sort of look at how we can address this in a much better way than currently asking the question verbally when the woman might have the man in front of her, which is not appropriate. Another challenge, particularly in the public sector, is the lack of ongoing relationships with health professionals. So quite often you have a different midwife at every appointment. You don't have that continuity of care. So you don't have that opportunity to develop a relationship with the person that you're seeing, as every visit might be with a different health professional. So that can also be an impediment to disclosing, for example, issues around emotional or mental health, or issues like family violence with a health professional. And so it is another barrier to screening. Language barriers are another factor here. Quite often we don't have access to the recommended screening tools in different languages, or certainly working in public or other hospitals where the screening is being asked by a male interpreter in the waiting room, which is totally inappropriate. The way the questions might be interpreted by an interpreter might not be accurate. So these are all language barriers which also need to be considered. The different questionnaires also have a scoring system, and the scoring gives us an overall level of risk or likelihood that the woman is experiencing a mental health problem. But because often the health professionals are very rushed in their appointments and time poor, there's often not the time and dedication needed to give time to that scoring and interpretation of scores. So we know there's often inaccuracies in the scoring. In fact, on the Edinburgh scale, there's been seen to be up to 29% error rate in adding up the scores because there's a number of reverse scoring items. And this, of course, then can lead to an inaccurate overall assessment and referral for diagnosis. Another thing, certainly, from looking at the whole idea of asking the questions verbally to the woman or getting the woman to complete the questionnaire, is that often women don't get anything back. So we've been looking at how we can try and transform this by empowering women to actually receive their own client report, as well as empowering the health professional with accurate reporting and some guidance around what to do next based on the different outcomes of her assessment. Data collection with pen and paper is obviously also an issue. At the end of Australia's National Perinatal Depression Initiative, we've invested over $85 million in a routine national screening program, and at the end of that we have no idea about who was screened or what the outcomes of screening are, because everyone is collecting data on pieces of paper and questionnaires, which is really not acceptable. I mean, we would never not record results of pap smears or other tests, but this is again what has happened in the emotional and mental health space. So we have no good data to know what the rates or outcomes of screening are, and of course that impacts on our ability to refer people or provide services based on where the need is in the community. So these are all barriers to screening which currently exist. And so certainly as one of the key mandates of COPE, establishing COPE in 2013, was looking at how we could revolutionise screening and address a number of these issues. So we've developed the iCope digital screening platform, and this enables women to do their screening either in the waiting room or in the consultation on an iPad. And we've been rolling this out across a number of maternity hospitals and postnatal settings. And there's a number of key advantages to the iPad platform. One is that it saves a lot of time updating the latest tools onto the iPad. We know that this can take between, on average, 4 to 6 minutes to do the screen. The system also produces instant clinical reports and reports for the client. So this is an example of the summary report developed for the health professional. So this really goes through, obviously 100% accuracy, adds up their scores and provides advice to the health professional around what to do next based on their scores, their risk factors, and also their Edinburgh score. So it also is recording this data electronically. This can be uploaded into patient records, and it's a much, much more efficient way of actually undertaking the screening. Another great benefit of the digital platform is that we have programmed this to enable screening to be undertaken in multiple languages. So the woman can select the language that she wants to, and then the screening tool and her client report will be made available to her in her own language. So she, when doing the screen, can say, I'd like to receive a copy of my own report and I'd like that delivered either to my email or SMS. So she can choose A, if she wants her report, and B, where she wants that sent. So for someone who might be experiencing family violence, for example, they might choose to send it to a different email address or a different number, or they might choose not to have it sent to them. So it's really empowering the woman with that choice around where she wants that information sent to. And of course, we provide guidance to the health professional. Certainly the client report, which here is an example of how it might be delivered and presented on their phone. It not only goes through what their results of their assessment meant today, but also provides them with links to further information on any risk factors or her likelihood of developing emotional and mental health problems. So it's certainly about empowering the woman with information as well. Now, one of the challenges around family violence, particularly I suppose when we're talking about screening, was the men being there at the point of screening. So another new facility that we've just built into the digital platform is the ability for a client or a service provider to say, well, we don't want to include the family violence in the general screen, but we'll rather remove it from the general screen, from the general iPad, we will then prompt the health professional when they go back into the back end of the computer to get the clinical results. It's at that point we will prompt whether the woman is alone, and if they say yes, then we'll ask the family violence question. So there's ways, again, that we can really harness this technology to cater for the different scenarios and situations and address some of these risk factors which currently pen and paper screening and traditional approaches to screening aren't managing to do. So here's an example, for example, of if a woman did indicate family violence, we would link her through to pages on the COPE website which deal with each of the risk factors. And here's just an example of the risk factors around family violence. We very much tailor our information to where the woman is at in the perinatal period. So if this was an antenatal screen, we would take her through to the information around family violence in pregnancy specifically and talk about the risks in a pregnancy, as opposed to the perinatal period or the postnatal period, where we talk about the other factors, other risks, and the safety of the other children who might be in her care and the infant. So very much tailoring the information to where the woman is at in her perinatal journey. I'd just like to move on now finally to the area of referral and treatment. And quite frankly, when it comes to referring people at the moment, we're really reliant on the health professionals and services knowing and having a good idea where to refer people. Often this is based on pieces of paper or word of mouth about who's a good doctor or who's not a good doctor. And this is again an area where we're really looking to harness technology and make the referral process better, both for the frontline health professional who needs to identify services for the risk factors or the mental health treatment, but also for the patient herself who may require or want to know where she can get help following screening or at any other time in the perinatal period. So at the moment, the barriers including not knowing where to refer, having access to services. At the moment, it is really potluck when you go to your GP, whether they really understand perinatal mental health problems. We have lots of cases where women are told that they just need to go home and have some rest. Meanwhile, the woman might have be developing severe postnatal depression. But if the GPs or health professionals don't have this specialist perinatal mental health knowledge, where this is an opportunity for these women to slip through the cracks. It means that these women are going to develop more severe mental health problems, and we know that 74% of women do not seek help until they reach crisis point. And with mental health problems in this period being the leading cause of suicide and maternal death, we need to have easy access to referral, not only referral, but quality referrals where we have the confidence that those health professionals have the knowledge, skills and competencies to provide evidence-based treatment for pregnant women and new mothers. So in response to this, we're going to be developing, again, this is funded by the Commonwealth Government, a new eCOPE directory. So as part of this, we'll be developing national standards, accreditation standards, which we will require health professionals to have in order to say, I'm an expert in providing treatment for example, postnatal depression or antenatal anxiety. And once we have those national standards, we'll be assessing health professionals against those standards to identify who does have the expertise so we can increase our levels of confidence around those services when we're referring women. But certainly all the information that I've covered today is covered in depth on the COPE website at cope.org.au. And you'll see there just across the tab at the top, we very much break down the information to be relevant to where women are at the time. In the tab at the top for health professionals, that's where you'll find all the evidence of the latest guidelines, screening and assessment tools. And there's a whole range of fact sheets, both for health professionals, but also for consumers on all of the different topics raised and all the different mental health disorders covered in the national guidelines. So that's really my presentation for today, but I'd be really pleased to take any questions that anyone might have. And with Inez, we'll bump through the questions. Thank you very much.
Thanks very much, Nicole. We've had quite a few questions come through, so I might take the first one to allow Nicole to have a look at some of those that have come through. Excuse me. So there's been quite a few questions around how you might identify someone who is experiencing family violence when they come to you. You can't always identify it, I suppose that's the first thing to say, but common things, Nicole mentioned a few times, having the partner in all of the appointments, so jealousy and possessive and controlling behaviour is certainly a big indicator of someone who uses violence. So if you're noticing that, looking at ways where you're able to meet with that woman and discuss things in a private setting away from the partner. A common tactic of people who use violence is to interfere with their appointment scheduling. So if you're finding that a woman that you're supporting is missing her appointments or coming late, or you call her because she appears to miss it and she thinks it's on a different day, that can be a sign. Women who have reported, being punched in the abdomen during pregnancy. So if there's bleeding or bruising or tearing, that can be a sign. Often women who are isolated, so report no other support networks, or are suddenly having a lack of support networks that she used to have, can also be a sign. I suppose what I would also point out is that many women don't actually report family violence even when they're asked directly during pregnancy, and there's a range of reasons for that, most commonly shame and guilt around experiencing violence, which is a really common reaction to anyone who experiences intimate partner violence. So practical things you can do is mention that it's actually really common for people to experience violence during pregnancy. Having websites up or information around services like 1800-RESPECT to let them know that they can contact services services anonymously because they may not feel comfortable to respond to you and they may want to do that in an anonymous way. You can do practical and early intervention suggestions like ensuring that they're linked into a mother's group, to community supports, or even offering them information that there are those support networks out there. So they can be some practical things you can do, but really providing different ways for women to know that this happens during pregnancy, that there's services that they can go to, specialist domestic and family violence services. And as Nicole said, providing ways and choice for how a woman discloses and the manner in which she discloses during the time that you're working with her in the perinatal period.
And if I could just add to that, certainly in the Ready to Cope guide, we very much focus on, an addition of each the antenatal and the postnatal period around family violence in pregnancy, what it is, and we certainly promote the 1-800-RESPECT all throughout the Ready to Cope guide and throughout the website. So it is really our first port of call where we refer people, but also the Ready to Cope guide really provides us with a very gentle opportunity to explain what family violence is, how it might present, and where you can get help or talk to someone around family violence in the perinatal period as well.
Great, thanks, Nicole. There's a couple of other questions that have come through. Is there any in particular that you want to
address? So we may as well start at the top. We had someone asking about what about people who don't have access to computers or emails for to access the information, the Ready to Cope guide. We will be also making this available via text. For example, we know that when we're developing the Aboriginal and Torres Strait Islander versions, and also for the different languages, a lot of these cultures don't have email, but this is the biggest user of smartphones, and particularly in the perinatal period, women are getting all their appointment details and things via SMS and text. So certainly we are reaching the majority of this audience when it comes to using mobile technology. And of course, this does provide us with a unique opportunity. People can also go onto the COPE website and link in and go forward and back and look at the different information. But all the information contained in the Ready to Cope guide is also available through the COPE website, which is available through public libraries or other sources. We asked the question here from Debbie, will the tool be introduced in public hospitals, and is the current Safe Start tool being replaced? Certainly we're working with New South Wales Government, and they are looking at modifying or reviewing the Safe Start tool to be in line with best practice. A lot of states, including I think New South Wales, now South Australia, are already using the Antenatal Risk Questionnaire, or the ANRQ, which is recommended in the guidelines. So for most states that's already encompassed in there, so there might not be a change because you're already using the ANRQ. In relation to the pen and paper versions, of course, can be used anywhere, and also the digital platform is being currently rolled out across a range of public and private sectors. And another question I saw is around whether it can be used in outreach centres as well. Yes, it can. And I'd be very happy to take more questions on the use of the iCope screening platform around a whole range of different types of health services and different health settings. So not only antenatal and postnatal setting, but we're also using it and adapting it across inpatient units, for example, where we're looking at people before and after coming in for mental health treatment in a mother and baby unit. We're using it in parenting centres where people coming into parenting, having parenting courses and interventions, or also we're using it, adapting it with the questions to use in infertility settings to look at mental health amongst couples going through IVF. So again, the technical and the application is very vast across different settings. There's a question here from Vicky around what are the rates of availability of mental health screening across the perinatal settings. Well, the truth is here it's so variable, and it really comes down to the individual health service about whether they are currently doing screening or not. Again, this is where mental health is often the first thing that drops off, and the other physical health things get the prioritisation. So it really comes down to often, sadly, to leadership within organisations whether they are doing screening or not. Having said that, it is a little bit different in New South Wales, where they actually have the Safe Start policy. So this is a statewide policy which says that every woman must be screened antenatally and postnatally, and that certainly helps lift the rates of screening when there is a policy in place. But in Victoria, for example, we're very good at postnatal screening within maternal and child health settings, but antenatal screening is very, very variable across different maternity settings. It certainly seems to be increasing with the new digital and more cost-effective and time-effective approaches and more inclusive approaches, but we still do have quite a long way to go in relation to that. But all of these resources are slowly being updated both in the public and the private sector. And of course, you know, uptake in the private sector is probably increasing at its most now, that these health professionals like obstetricians or GPs are actually being reimbursed with Medicare rebates to actually undertake screening. And that, as I mentioned, is to try and lift the rates of screening in the private sector where it wasn't taking place at all. Yeah, so Inez, you might want to answer the questions around why the risk of family violence is higher at this time of life.
Yeah, thanks, Nicole. So Nicola's asked that question, why is the risk of domestic or family violence higher in the perinatal period? There's generally a consensus that this is a time where women have more control and self-awareness of their bodies. They're receiving a lot more attention during their pregnancy, and for people who use violence, their control and possessiveness can increase experiences of being jealous and trying to control the movements of their partner, who they interact with, and limiting their access to their family and friends, trying to be in all their appointments rather than letting them go to their appointments themselves. But, you know, we can never say definitively why someone uses violence, but most people would say that that increase of a woman's independence away from her partner during pregnancy is certainly a factor that plays into increased behaviours of jealousy, possessiveness and controlling behaviour.
Another one of the questions here is around asking questions when others are not around, or it might not be appropriate to ask a question. Certainly then, this is where providing the woman, rather than asking it verbally, maybe providing the woman with the questions on a questionnaire, a paper questionnaire, or of course the digital platform is a great way. And we're finding that, interestingly, when women are actually doing the screening digitally, so on the iPads, the rates of disclosure around family violence seem to be higher because there is almost like this reflective process where they've indicated at the beginning of the screening tool, yes, I do want a copy of my report. So the information that they're going to get back from their personal report is only going to be as good as the information that they put in. So this sort of increases the awareness, I suppose, that what I'm going to get out of this for myself will depend how honest my answers are. But also, I think, doing it digitally, but it's between you then and the platform as you're reflecting and answering the questions. And this is a great advantage over asking the woman often directly face-to-face when it comes to sensitive issues like family violence or mental health symptoms, because the woman might be very ashamed or embarrassed or worrying about how she might be perceived by the health professional. And we know health professionals have varying levels of skills and abilities in asking these questions and making the woman feel comfortable. And with the number of barriers that I talked about when it comes to screening, you know, the time and the availability and the environment, this is where we're actually seeing that the digital tools have a great benefit of giving that woman time and space without fear and judgment to actually answer more honestly at the time of screening. There's also a question here about women who may choose to terminate a pregnancy. Should they be screened as well? In this case, I wouldn't recommend screening using these perinatal mental health screening tools, because these are specifically for pregnancy and the postnatal period. But certainly other tools could be useful to use here. For example, there's a tool, there are specific grief tools, or there might be tools to look at stress, depression and anxiety, which aren't specifically related to the perinatal period. So that these are different tools that could be used, but I'd really talk, it's about talking with a woman and identifying if there is issues that she wants to talk about, and then you would choose the tool rather than doing necessarily universal screening. A woman's reasons for a termination might be very varied, and the responses that might give might be very varied. So it's really probably much more individualised. But if you are concerned about different mental health problems, then it would be about really, I would think, choosing the tool that fits what you're concerned about within the woman.
I might just add to that too that there is an opportunity there if someone is coming to you for a termination or has had a termination to ask the question around whether they're worried about their relationship or if there's anything going on in their relationship that they're worried about, to let them know that there's supports out there. Again, it might not be a time where a woman wants to disclose that that's what she's experiencing. And certainly what we also know is some women might not yet identify that what they're experiencing in their relationship is abuse and violence if they're living with that. We had a question earlier around what if a woman doesn't recognise that she's experiencing abuse, for example, if it's tech facilitated abuse or financial abuse. What we can say is that people who use violence don't just use one form of violence or abuse. So what we commonly hear is that there's emotional and psychological abuse, there's controlling behaviour and limiting access to family, friends and support networks. Financial and economic abuse is very common in intimate partner relationships and in domestic and family violence. So, you might indicate that you've noticed these things, and again, if they've got worries about their relationship, that they can contact services like 1-800-RESPECT. The reason that I would also frame it like that is because what we know at 1-800-RESPECT is that when people contact us, it takes them time to open up and discuss what's going on in their relationship. So very few people come straight out and say, I think this is what's happening. They want to build a sense of trust and safety before they disclose. And they're often the nature of the abuse that they're experiencing, so the emotional abuse, the confusion that they experience in the way that they're being treated, that can often take them time to say, this is what's going on and I'm not sure about it. And at that point, we're then able to say, when they're working with a 1-800-RESPECT counsellor, that sounds like violence and that's not okay, or that sounds unsafe. So if you're ever working with a woman and she indicates in some way that she is worried about her relationship or there's a lack of safety there, that you can choose to ask her the question directly, and then if she is able to talk to you about that, then linking her into appropriate services. But I would also say that having information accessible to people in your waiting areas and in your consultation rooms is really important as well. So having the COPE details up, having the 1-800-RESPECT details up. Nicole mentioned earlier that we're now a smartphone savvy generation. There's also the Daisy app that you can encourage any of your clients to download, and that gives tips on safety planning services in their local area, and it's available in a number of languages. So for people that you're working with who might speak English as an additional language, that's also a really great resource. Nicole, just before we finish up, is there any other questions that you wanted to touch on?
I think we've pretty much covered all the questions that I can see here. So, but absolutely, feel free to, you'll be able to find me on the website. If anyone has burning questions that come up later, I'll be very happy to answer them.
Thanks, Nicole, and thanks for joining us, everyone. Today's webinar will be available on the 1-800-RESPECT YouTube channel shortly. And a case study will be on the 1-800-RESPECT website soon too. You'll receive a notification when that goes live, so feel free to share it with anyone you think might find it interesting. Thanks to everyone for joining in today.